This third plenary session talk was around immunotherapy and adding it to standard of care for limited stage small cell lung cancer. So anytime something new happens in small cell lung cancer, I get extra excited because so little has happened over the last 50 years, and that's really started to change over the last few. So Dr. Herbst, what do you want to say about that?
Well, who would have thought, 10 years ago, we'd be talking immunotherapy, not only in small cell, but non-small cell lung cancer. But immunotherapy has changed the landscape. I think most people on this living room know, but, lung cancer is one of the top 2 or 3 cancers where when you reactivate the immune system with these so-called checkpoint inhibitors, drugs that allow the body's own immune system to target the cancer, whereas prior to that, it was being blocked by forces that the tumor produces, we can see a benefit. And of course, in non-small cell lung cancer, I think everyone knows, or we can talk about it, phenomenal benefit. But in small cell lung cancer, Danielle's right, there hasn't been that much benefit. About 3-4 years ago, we saw, maybe it's 4, we saw that durvalumab, a PD-L1 inhibitor, targets an immune checkpoint in patients with advanced small cell lung cancer. We call that extensive disease, whose small cell lung cancer is spread outside the lung. They would get their chemotherapy, platinum therapy, something called etoposide, and then they would also get this drug, durvalumab, and actually they saw a benefit in their progression-free and overall survival. But to this day, no one had looked at this in more limited small cell lung cancer. In limited small cell lung cancer, this is, small cell lung cancer is about 10 to 15% of all the lung cancers, and limited is probably about 1/4 to 1/3 of them. So in these patients that have limited disease, the disease is confined to one lung, to one area where one could give radiation therapy. And in those patients with limited small cell lung cancer, they get chemotherapy and radiation together. And actually, 1 out of 5 is cured. It's very potent. But that's not good enough. We want 100%. So we're always looking, and that should be a theme of this living room. Progress being made, but we need more. We always need more. So, so this durvalumab was now used in those patients. It's called the Adriatic trial. These trials all have names of major bodies of water. But in the Adriatic trial, the durvalumab was used afterwards, and lo and behold, improvement in progression-free survival and in overall survival. So now, very quickly, it's, again, still awaiting the FDA approvals. I was just on a guidelines call today, and we added this to our guidelines, but we're put an asterisk waiting for the approval. Now, if you have limited small cell lung cancer, immunotherapy now becomes part of the equation. So this abstract also was met with a great deal of excitement. Dr. David Spiegel from the Sarah Cannon in Nashville presented it. There was a discussion for this as there was the other one. Both discussed and said, we have a new standard of care. And again, can't remember an ASCO, and I've been going to ASCO since the 1993, so 30 years. I can't remember, and I haven't missed a year. Gosh, that's a lot of meetings. But I can't remember seeing 2 big presentations like this, one in small cell, one in non-small cell, changing practice. And, gosh, I get 2 or 3 CVs a week from young people wanting to work in the lung cancer area. Back when I got my job, I just waltzed right into the job because no one wanted it. But we're making progress.
Yeah.
But again, I know there are people on this call who are still fighting lung cancer. It's not good enough. There's tangible progress. I can tell you I've seen it over my 25-year career, but we need more. And that's why research and science is important. But I also, and the reason I love these living rooms is people need to have knowledge about what they can get, because I worry about people who never get offered these immunotherapies or get offered these targeted therapies or get offered the profiling. So that's something that all of us have to do, is increase the awareness so that we can help more people with this disease.
Yeah, from your mouth to God's ears, I think that's one of the things we talk about so much here, particularly in the community setting, particularly in the more rural community settings, where access to this type of information takes a little bit longer. It's like swimming upriver to some of these healthcare providers that are providing care in those centers. So the more educated the patients and their caregivers and loved ones can be to have these informed conversations with their docs, the better.